Hi, everyone, and welcome to Beyond the Labels, Embracing and Supporting Your Loved One with BPD. I'm Vanessa with Unsinkable, and I'm really glad you're here today. Whether you're a parent, a caregiver, a friend, or just someone wanting to better understand borderline personality disorder, this space is for you. Before we begin, a quick content note. Although we approach this conversation through a trauma-informed lens, we want to acknowledge that today's discussion may include references to mental health challenges, emotional distress, and personal experiences with trauma. We understand that this content can bring up strong feelings, so please take care of yourself in whatever way you need, whether that means taking a break, stepping away, or reaching out for support. You're welcome to engage at your own pace, and your well-being matters here. We know this journey can be tough, and it's full of questions, emotions, and sometimes a deep sense of not knowing what to do next. So today isn't about having all of the answers, but it is about offering support, sharing tools, and helping you feel a little more seen and a little less alone. Our panel brings a mix of professional insight and real-life experience, and they're here to talk about what it means to support, not fix, someone you love. So we'll also touch on things like caregiver self-care, communicating with empathy, and how therapy can play a role. So thanks again for joining us tonight. Now let me introduce our group of amazing panelists. First, we have Maria Rosa Gouveia. Her personal journey as a mother navigating her daughter's BPD diagnosis, coupled with her extensive volunteer work, has given her a wealth of experience and empathy that she generously shares with other parents and caregivers. In addition to her peer support role, Maria Rosa has served as a workshop coordinator, helping to facilitate discussions, educate, and support skill building for individuals and families affected by mental health conditions. So welcome, Maria Rosa.
Hello, thank you for having me.
Next, we have Dr. Andrew Howlett, who is a child and adolescent psychiatrist and assistant professor at the University of Toronto. His areas of interest include adolescent, family, perinatal, and father's mental health, and his hospital-based practice addresses acute care needs and takes a patient and family-centered approach to treatment and recovery. And he also happens to be a proud board director for Unsinkable. So welcome, Andrew.
Good evening. Great to be here.
And lastly, we have Maria Estrada. Maria is a passionate mental health advocate, speaker, educator, and professional child and youth counselor specializing in mental health and addiction. Maria faced mental health challenges such as navigating BPD herself and experiencing stigma firsthand. So this led her on a journey of self-advocacy, diagnoses, relapse, and ultimately recovery. Now, Maria uses her personal story to support others. She is currently writing a multidisciplinary memoir that expands on existing borderline personality disorder literature by exploring her lived experience on both sides of the mental health care system. Welcome, Maria.
Thank you for having me.
Awesome. So thank you all. Now, my first question is going to be aimed at Maria. So Maria, if you feel comfortable sharing, what did receiving your diagnosis mean to you at the time, and how did it shape your understanding of yourself?
Yeah. So I was diagnosed with borderline personality disorder when I was 17, and I always struggled with my mental health in general, navigating the ups and downs, the intensity of just how I was feeling, the different types of diagnosis along the way. And when I was hospitalized, a psychiatrist came into the room and said, like, do you know what borderline personality disorder is? And I had no idea. I, had the understanding of what I already had in my diagnosis. And as he's telling me, all of the things that I am experiencing, it was a moment of like, I found my puzzle piece because I realized that like, I'm, I'm not crazy. Like, there's nothing wrong with me. My brain is just sick. And everything is starting to add up. All of the, the intense feelings, the not being able to really have interpersonal relationships, really, like, they all came together in that one moment. And it was just that I felt seen, not just by the psychiatrist, but myself, because I, I realized that I'm not broken. There's nothing wrong with me. My brain just struggles. And now I know, and I can, figure out a way to support my brain, and then support myself.
Awesome. Well, while coming to understand your diagnosis, how did your family dynamics help influence your journey?
Family is complicated. I myself don't have the greatest family dynamic. Come from a place of not talking about mental health. It's very taboo. And me coming into this world already being complex, and having all of these, wonderful things about myself, my mom really had a very strong reaction to pull away and to, be in denial. And that being, my mom and I in Canada for a long time, it was devastating because I was navigating, what is wrong with me. Clearly my mom sees that there is something wrong with me, because there is that piece of, shame and guilt and language that wasn't really helpful. And, now I see it that, she didn't know any better, right? Like, if you don't talk about your mental health, like, why did I expect her to know all of these complexities? But it was very difficult for me as, I came to Canada when I was 6, 7, and I kind of grew up really, really fast and navigating just the world, and then, the diagnosis, and I made it very lonely.
Yeah. Maria Rosa, what did the early stages of supporting your daughter look like, and how did your understanding of BPD evolve over time?
Well, in the beginning, when she was very young, she had very big emotions. She was easily upset and had tantrums. There was no diagnosis at this point or mention of BPD due to her age. And I think it was probably grade 6 that I noticed that she was scratching on the top of her hand, which, looking back now, was the early stages of self-harm and self-soothing. She avoided school. She often refused to go. This lasted through high school. She declined school activities like school trips or participating in presentations or any team-related activities. The strategies that I had, looking back, which I forced her to go to school. I would change plans to accommodate her feelings. I would request special accommodations to avoid putting her in an uncomfortable situation that I knew would upset her. And essentially, I was walking on eggshells to fix this situation. I also coached her siblings to take on the load, to deal with things on her behalf, because I didn't feel confident enough for her. This changed over time, of course, but that was what the beginning looked like.
Yeah, very different experiences, but very similar for both Maria and Maria Rosa. And that's why we need to have conversations like the one we're having today. And I want to pose a question to the group. From your experience, what are some common misconceptions that people have about BPD, and how do you challenge the stigma in everyday conversations or systems?
I can go first, I guess.
Yeah.
You know, they're known as dramatic, manipulative. Some of the words that I remember thinking of, they're attention seeking. But these are all very misconstrued. That's not at all what they're doing. That's what they look like. And I think when you understand the diagnosis and you look past the behavior and look at the child or the young adult or adult as they grow, because this does not go away, we see that those are actually not at all what they're doing. And I'm sure Maria and Andrew can add to that.
Yeah, thank you. Yeah, I mean, as a person kind of that received a lot of the labels and the stigma, there is that common piece that Maria Rosa said around like manipulative. And my mom always kind of used the word demanding, demand too much. And my ability to feel every feeling all at once was labeled into the, attention seeking or like dramatic. And we use that language in our everyday life. And, we say, oh, this person's crazy, this and that. And for myself, that was like receiving all of the negative side of BPD, not just from myself, but like family, professionals, that really did a lot of damage.
Yeah, there's a fire alarm going off here. I hope, it doesn't disrupt things. But yeah, I would say a few other kind of misconceptions around borderline personality disorder would be, that it only occurs in women, and that's not the case. Men can certainly, be diagnosed with borderline personality disorder. The other thing too is that with that condition, there are 9 kind of areas of potential symptoms or difficulties, and a person only maybe has to be struggling with 5 of those 9 to be diagnosed with borderline personality disorder, which means that there's lots of variability and variations, and so not every 2 people that have borderline personality disorder may be experiencing the same thing or having the same difficulties. And so, I'd say another misconception would be that the person with borderline personality disorder is struggling with self-harm or chronic suicidal ideation. While those are certainly important aspects of it, not everybody with borderline personality disorder would necessarily have those experiences. So there can be quite a bit of variability, and it can happen and for all of us, and not just women.
Yeah, thank you all for your input. It sounds like, the diagnosis is so much more than those misconceptions that people tend to associate with it. And it's just a lot more complex than that. Andrew, I want to ask you, how do you approach explaining the symptoms of BPD in a way that respects the individual's lived reality and avoids pathologizing their experience?
Yeah, I think one thing to categorize the condition a little bit is recognizing that components of it can include the way a person thinks about themselves and others and their relationships, as well as their behaviors and a variety of different behaviors. And so I think one way is to acknowledge that how they're thinking or how they're behaving may be driven by some really intense and genuine emotions for them, whether it's just fear, feelings of abandonment, feeling completely misunderstood, shame. So often like intense feelings can kind of drive their thought patterns or their behaviors that are becoming issues for them. And I would say that initially, like, a behavior is a way to, like, protect oneself, want to kind of restore a situation, to resolve kind of a really intense and difficult feeling. The problems become when those behaviors or things may not be working for them anymore, and they're still remaining in distress, and then that results maybe in different types of behaviors, and those behaviors might in some ways feel like it's working for them, but it also may be risky or having impact in other ways. So when the behavior is not working, or when we become worried about their safety or its impact on others, we want to kind of acknowledge that and try to help them sort of address that and find different ways of coping with a lot of distress. So I say that it comes, these things come out of real genuine, like, intense feelings. And for some, they might be able to recognize that those feelings come from, past experiences, for themselves, whether it's in the context of relationships or with their family, or a traumatic incident. So I think we can, try to connect the dots from lived experience. Intense feelings may have resulted in, in behaviors or a way of thinking that may have settled them in the moment, but have become problematic for them, and perhaps that's why they're in this getting help at that particular time.
Yeah, I love that that relation is a survival instinct for them for sure.
And
Maria, I saw you came unmuted yourself.
no, it's kind of Andrew's talking about, the criteria for BPD. And when I got diagnosed, I went through like 8 hours of, really exploring the diagnosis, because it can't be, it's very complex, and turning it into like the professional side as well. I realized that, putting my lived experience hat and also my professional hat, I realized how reading all of the 9, they sound so scary. And, when you are explaining that to a parent or, a caregiver, whoever, like, I was reading it and it was very scary. And it really does talk about the, like, humanizing that I'm a person, and yes, I do have abandonment issues, and it's trauma related. And just because till this day I meet 8 out of the 9 and still in remission, doesn't mean that I'm less of a person and I'm just symptoms. And the way that, Andrew really explained it, like, I wish that I got that explanation, because then it didn't seem scary when, coming from that human perspective and not the points.
Absolutely. When you're receiving a type of diagnosis like this, you are not your diagnosis. You are a person living with that diagnosis. So that is very important. Thank you, Maria. Maria Rosa, we would like to know, how did your understanding of BPD shift over time as you supported your loved one? And were there moments of clarity or learning that stood out for you?
Yeah, in the beginning, I want to say around grade 7, my understanding of it was so little. I sought a doctor's help, which is where she was medicated at that time. She was put on Prozac as young as grade 7, which is an antidepressant. I also had received a referral to Reach Out Center for Kids, known as ROC. It was through ROC that I started to receive some education around the early signs of BPD, again, not knowing what BPD was, never even understanding it, but more so what it kind of looked like. The thing that stuck out most was the emotional dysregulation. Later, I came to understand through her diagnosis that she was a deep feeler. She had a fear of abandonment. There was trauma, and trauma doesn't have to be a big, profound event. I learned that trauma over time was her perception of the situations, and that they started to shape her experiences as traumatic. And she was developing these coping skills that we saw as disruptive behaviors. And for her being so over emotional, but really, she was just trying to cope with all the heaviness she was already carrying. And to Maria's point, with the brain, it just was not working the way it should. My true moment of clarity came when we were in therapy and we were discussing how she throws herself on the floor or closes herself off in her room to isolate herself. And the therapist suggested that I get on the floor with her and ask permission to enter her room, basically to meet her where she was instead of pulling her where I was at. Wow, that was huge. When her answer was no and she protested, I started to share that I was worried about her and that I just wanted to help. Again, being given permission to be a human and not just her mom was the message I was receiving there. And I came to understand that BPD meant that she was walking around overwhelmed with emotions, immense feelings of guilt for sharing your air, that she was a burden and that she was trying to navigate life while feeling highly anxious and at the same time very sad and depressed. That was just so huge for me. I was very lucky to get that support. And it was when I sought the support that things started to shift. So that was my wow moment.
Thank you so much for sharing that, and definitely loving the part where, you're meeting, you met your daughter where she was at, and that transparency with her instead of, again, trying to fix the situation into what's something that is most comfortable for you. You're putting her needs first, and that's incredible. It's not easy to do, especially in those bigger moments. But thank you for sharing that. Maria, what is one thing that you wish people better understood about living with BPD?
I wish that people knew that feeling all of my feels is not a bad thing. And that just because I have done things that I wouldn't recommend or wouldn't do that again, doesn't mean I'm a bad person. And I learned that, bad people don't feel bad for their actions, good people do. And throughout my recovery, like I worked so hard to make amends. And I also wish that people understood that you don't have to walk on eggshells. If you just sit there with me and not say anything and share that space, that's enough. And trauma itself, it takes people's power away. And people with BPD, there's a historical evidence of trauma. And that having my power at times where I'm feeling a little more anxiety or in that distress, providing me with as much power over the situation is huge, because you don't need to fix my problems. I'm not a car and you're not a mechanic. There's no fixing. I just want you to be and let me also navigate, because I am my own expert. And yes, it looks really messy if you look at my history. But at the same time, I got my needs met the only way I know how, because I knew what I needed at that time. So that's what I always say to people, and also how I support just people in general. Yeah, that was it was a lot. Had to summarize it.
For sure, but necessary and very well said, for sure. Andrew, how can caregivers and loved ones work alongside mental health professionals to create that supportive care network?
Yeah, no, great question. I mean, I think, one thing I discovered, in my training was that, in the area of like mental health disorders, they have such a bigger impact, on relationships than say other like medical conditions. And I think in part because the mental health condition as it affects the brain in a way that it can influence how a person sees themselves and others and within their relationships. And when others don't understand, or when there's concerns around stigma and so forth, it can have a real kind of detrimental impact, on relationships. So I think, being mindful of supporting relationships along with the person, is really important. I also think, like in the condition of of BPD, is that the reality is that a lot of what troubles a person happens in the context of relationships. I think they really find relationships helpful in terms of addressing their symptoms, but also some of the challenges can occur within that relationship. So really recognizing that and addressing that alongside as the goals of patient care is really important. Yeah, I think, involving, family members from the beginning is important. I think they benefit a lot from psychoeducation around the condition and how it impacts them. I think it's also important to recognize that, parents, caregivers, partners, are also going to experience intense feelings, with their loved one who may be struggling with BPD. And we've heard earlier talks of like, describing somebody with BPD as manipulative or so forth. And really, I think it's like, a caregiver or a partner, loved one feeling manipulated. And so, I think we can explore that. That might come from a sense of really just, feeling helpless with your loved one, powerless, scared. And the reality is that your loved one with BPD might be having those exact same feelings. So I think there's opportunity to to try to understand and empathize what a family member might be going through, and in doing so you kind of model the empathy and the validation that the person with BPD also requires. So I think looking to them, encouraging them to seek out their own support for those programs that are available, and to help sort of understand their experience and feelings when things do get tough. And yeah, and I think they helping them tolerate the distress of their loved one will help that loved one be able to sort of tolerate their own distress, which is one of the main goals, I guess, in treatment. So yeah, I think they're kind of a critical component to care, and lots of opportunities to to help the patient and the family by involving them.
Absolutely. A support system is incredibly valuable, and the more education that you can provide yourself and gain just allows a better understanding, right? Exactly like that. And it's so the power of language, from manipulative to, seeking support, feeling helpless, feeling powerless, spins it to a completely different perspective that, like we said, and Maria had mentioned before, is very much humanizing. Like, people living with borderline personality disorder are humans at the end of the day, point blank. This is a question for everyone. Can you share a moment, personal or professional, that shifted how you think about BPD and those living with it?
I can go.
Yeah.
I mean, I can, share both sides of it. The biggest piece that I really shifted my my perspective, not just like about me, but the people that I've supported, is the word like manipulative. And if you know me and we're talking about language, I will go off on a whole like education around it. But that word is so heavy and it's just very icky, right? Because that word also says bad. That person is bad because they did something, and for me, the way that I shifted it is resilient. And it is the fact that that person is getting their needs met the way that they know how, which is, not the greatest. And like I said, highly don't recommend all of the things that I've done. But at the end of the day, I got my needs met. And that's being resilient. It's, survival of the fittest. And that's how I had to shift my mindset as to, what, like I raised myself and I was my parents' parent. I did pretty okay with navigating the complexity of being that person that has that lived experience. And then going to school and being intentional around the specializing in complex individuals, and that really included borderline, was because I saw how I was treated, how, people, my psychiatrist, God bless him, I love him, he's the greatest, but he's a child and adolescent psychiatrist, and I'm 29. And it's sad in a way of I can't get an adult psychiatrist because of my label. And also he sees the human in me, and he isn't like wanting to get rid of me because he just sees me as Maria. And a lot of the clients that I've supported, and Vanessa, we work together, both of our caseload were people with BPD because they didn't want to, and nobody wanted to work with them. And I loved it because they're people and they're spicy and they're like so complex, and like their world is very beautiful. And they don't see it. So we walk alongside them. So it was really around shifting the stigma and the language that I received.
Yeah, thank you, Maria, for sharing that. Maria, Rosa?
Just to build on what Maria was saying, coming from a caregiver point of view, is I shifted from how I felt about her feelings to how she felt about her feelings. It was about her and her experience and what she needed from me, not what I was willing to give to her. I always use this as an analogy around accepting that there was nothing to fix, or that I couldn't fix whatever I anticipated or thought was broken. I'll give you a very quick example. My son, Daniel, broke his leg playing soccer one day. Horrible experience. He snapped his tibia. And as a mother, I did not run to his side with supplies to try to fix his wound. I called 911 to get him the proper help. And then after understanding his injury and figuring out what he had actually broken, then I could provide support on discharge. That's how I shifted looking at this situation, is that my role is not to fix. My role is to support, to get the proper help, be it for myself, my family, or for her in any capacity that I can, be it our village, be it school, be it just between us as a team. Versus it's all on me. I got to get this done. It's my responsibility, which we take on naturally as caregivers, because that's our job, right? Keep them alive, keep them well, make sure they have food and water, a shelter over their head. But what do you do when it gets more complicated? You call 911. No, I'm joking. But in a sense, that was my big shift, was just realizing that I couldn't fix this. And by the way, it's not really that broken. So that was huge for me too when I shifted. But that also came from an understanding of what exactly borderline meant to her. and what she now had to experience and live with.
Yeah, thank you.
Yeah, for me, I think working in the area of child, adolescent, young adult, mental health, I would run into the possibility where I may be the first person to talk about borderline personality traits or disorder, with youth and their families. And I have to admit, I would be a bit hesitant because I don't think the name sort of necessarily is easy to understand how that sort of like fits with the issues, the behaviors the person may be having. But that being said, I have certainly, when a person is talking about all of these things and can't see any connection between them all, and finally here's, a name of something that might connect these things, that also might realize that they're not alone with these challenges, that's the light bulbs that go off, and the bit of relief, I guess. And in one family session, a dad said to me, I think I have BPD too. Like that explains what I've been going through, and so forth. And so yeah, I think the reality is that sometimes, like, it does, the name, does provide an explanation for all of these different things that might be going on. How could they possibly, be related? And in fact, there is this pattern that people do have, and can, relate and connect to, and not be the only one in the world sort of struggling, with these things. So yeah, and I'd say, like, I think youth these days are more familiar, with it, and so it seems to be a bit easier to talk about, but I'm mindful of its, historical factors and issues associated with it.
Yeah, absolutely. Progress is slow but steady. As Maria mentioned previously, when we did work together, any youth that were coming to us, BPD, it was because it was a warning label and everybody else rejected them. And my like personal shift in that aspect, because I had never experienced anybody living with BPD, I wanted to know what was so like terrifying, what was so scary, what was like, why would nobody touch these youth? And like Maria mentioned before as well, they were hilarious. Like they got through their days, they were able to do everything that like youth would do. It really wasn't, I was like, what's the big warning here? Like I feel completely safe. And it's just a lot of it's youth, it's adolescent. It's a very big transition that nobody, no matter how much you read or how much support you can get, is 100% prepared for. And so just all the perspectives. I love that people get a chance to hear this and that we're making that progress towards more understanding and more empathy towards everything as well. Maria.
Yeah, sorry.
It's okay.
It brings me back to when we did case management.
Mhm.
But something that Andrew was saying around like that being cautious is also something like so like meaningful, because you acknowledge the stamp. And I can't not say it's a stamp. I live with it. It's like on my forehead. I'm writing a book. It, I own it. But it is also sometimes easy to just label that behavior as BPD. And like we all have traits of BPD, right? Like, oh, feeling abandoned by a partner, by a pet, the bus. Like all of these things is what makes us human. But it is around the intentionality behind, the psychiatrist acknowledging. And that's what happened to me. I was prepped by the psychiatrist and my social worker, and we were like, okay, so this is a thing, and I just want to tell you that it's not the prettiest, to the world, but that's okay because we have a safety net together. And I like respect and admire the caution around just putting that stamp, because it does acknowledge the stigma and also the gentleness of walking that person and their, family through this process, and not just discharge and good luck, right? So I really appreciate that. So thank you, Andrew.
Maria, actually, the next question is for you. Could you speak to what the emotional experience of living with BPD feels like from the inside?
Yeah, I mean, it's it's awful. But yet very me. There is the thing that BPD is known for, having a third-degree burn, buffer your emotions. And when you see somebody that has that third-degree burn in the hospital, they're in a bubble because it hurts, the air hurts, and they have to be so cautious with making sure that that person doesn't get an infection and doesn't get too overwhelmed with the pain. Translating that into my emotions, it is the when I feel, and that isn't a bad thing. It doesn't, gonna make me go off and do things that are not normally myself. But it is also very difficult to navigate interpersonal relationships, because I look at my historical interpersonal relationships and they're not the greatest. And that gives me a lot of big emotions and, the intense fear of trying to be what that person wants me to be so they don't leave me. Right? Like, that's exhausting. It's exhausting to not be who you are. And I did that for, such a long time. And yes, when there are those intense negative emotions, it is a downward spiral. And it doesn't have to be, because what I learned through a decade of therapy is that plot twist, I am in charge of my emotions and they're not in charge of me. And that's something that riding the wave was just those emotions, and I was just kind of like choking and dying and like doing all of those things. And then I realized I'm actually a good swimmer. And, these waves are not that scary because I am in control of my emotions. And I'm not in control of Maria Rosa. So that's okay. I have to just be able to control what I can. And also labeling my feelings is like huge. Again, if you know me, if you worked with me, everybody should have the wheel of emotion. I have it on everybody's phone that I, my close circle. Gently, I'm like, have you looked at the wheel of emotions? And I have it, everywhere. Because my emotions were so big, and because they kind of like popcorn were exploding all over, I couldn't name them. And then that became bigger and bigger. And if I took my time to say, okay, so this isn't anger, this is irritability, this is, feeling left behind and, not capable, not good enough. And that really helped that popcorn be more regulated. But it's a lot of popcorns. And it's hard to, as a person that is high functioning, and it's a privilege and a curse. It's a privilege because, I'm able to do my advocacy work and do, the frontline work. But it's also a curse because you can't really see all of the things that I'm experiencing. So it is something that I label as it's a privilege that I'm high functioning. And the people that have BPD can be stable, right? That's, I think, a misconception as well, that you'll never have healthy relationships, or, you'll never have a life worth living. And I would like to think that I have a life worth living, still kicking around. I still choose every morning to, keep going. But yeah, it's a lot up here.
Thank you for that. That's very raw and vulnerable, but again, so necessary to put out there. And I know you mentioned having a life worth living, but I can attest that Maria does have healthy relationships in her life that she is accountable within. Not to be biased or anything, I am one of them, but there's such progress from when I first met her and when we first started out as colleagues to then continuing our friendship out of that. It's been a journey that I've never been afraid of. So, Maria Rosa, how did your relationship with your daughter shift as you began to better understand BPD? And how did incorporating a level of presence and empathy help you providing her with support?
Before I jump into that, I just want to acknowledge that Maria and I also have an amazing relationship, and I've known her since she was wee. So I just want to say, I just so proud of her and watching her. So first and foremost, please repeat the question.
No problem. So how did your relationship with your daughter shift as you began to better understand BPD? And how did incorporating a level of presence and empathy help you in providing her with support?
I think the biggest thing is I started to see her as a person, and I started to see us as a team, respecting that she had to navigate life's challenges and successes in her own way. I had to unlearn what I thought parenting meant, and she became my teacher. She was teaching me what she needed and how she needed it. And I started to see her painful moments as opportunities to connect with her, not fix or end it. It was very liberating for me to assume the role of student while also empowering her to connect her behaviors to her outcomes. As Maria said, giving her back that sense of control. She was in charge and I was just her sounding board. I was along for the ride. None of it was easy. She's 21 now, and I still catch myself trying to lead. I try to stay self-aware, and instead of statements, I've learned to ask questions. How can I help? What do you need right now? Which in turn, I hope has made it easier and safer for her to ask for help without feeling guilt or feeling like she's a burden to me or anyone in her circle. This is how we achieve the outcome of becoming a team. In doing so, she also stopped pushing the boundaries and she started respecting me because she genuinely didn't want to hurt me or others she deeply cared for. Again, coming from what Maria was saying, it's not their intention. They just love so deeply. So that was my big, huge leap, I guess.
Yeah, thank you. Maria, if someone truly wanted to sit with you in a moment of pain without trying to fix or change it, what would that look like?
You always get so emotional with this one. I have a dear friend. His name's Angus, and he met me when I was like 16. And at that time, the emotions were so intense, and my relationship with that boyfriend was so unhealthy, that, by the time it was like the 10th breakup and get back together, people got tired of going through this roller coaster with me. And Angus, he was driving me home, and I could feel the shame that I was experiencing, because plot twist, I got back together with that person, and I didn't want to tell anybody because they're gonna, say what everybody said, don't do it. And I think he could sense my internal like dilemma and crisis of that shame and guilt. And he said, whatever you're going to say, I'm never going to judge you for it. Nobody in my life had ever said that to me. And he didn't need to he never gave advice. He took 8 seconds before answering. But then I realized that nobody had ever said this to me. That, whatever thing that I've done or, did or whatever, that he wasn't going to judge. And that itself made the space so safe. Oh, thank God he's not here.
I think I would have loved to hear you that, and just this, yeah, and just the strength in that statement alone, I think is a great statement. If anyone is struggling to support somebody and they're really sensing that they're not able to really be honest, or a lot of the time it is because we feel like we're going to be judged and shamed and ashamed for what we're doing. And so coming out and saying, listen, I'm not going to judge you, I'm going to listen, makes a whole ton of difference for sure.
Yeah, and it clearly changed my life, and good or bad, he's the person that I go to. But then I learned that I will also take this with my own practice, right? And they have the same reaction of, oh my God, nobody's ever said that to me, Maria. And I'm like, right? This is a safe space. And it's those few words that, I was 16 and I still get emotional. So yeah, just be empathetic and sit with that person, because I was already ashamed. I didn't need to hear it. I already felt guilty. I needed to be met with compassion. And that's all we can ask for.
Beautifully put. Going off of that experience, what are some other things that people have said or done that made you feel seen, respected, or truly understood?
Sorry.
No, it's okay.
It took me a while to unmute. I think that the acknowledging the elephant in the room, when it comes to, professionals and getting the support that I need, but also not labeling the labels, right? Not being like, oh, you have BPD, is that why you feel A, B, C, and D? Because I already know the answer. And I think that also looking like the opposite of guilt and shame is that compassion, right? And being in a room of somebody that is empathetic and compassionate is enough for me to be able to shed all of the guilt and shame that I have. And even, like Maria Rosa would asking for consent and not stripping away my power. Like how can I help? What do you need from me? Is it okay if we just sit? Do you need tissues? Right? That's it. Or are you open to options instead of a solution? Because a lot of the times I don't want a solution because I want my power. And if you give me options, then that's great because I get to pick whatever it is. But it's the little details that mean the world to me.
Thank you. Some of the suggestions honestly seem like the simplest of things that you can offer another human being. So it's great to remember how much of an impact even the simplest things can provide. Andrew, the question I have for you next is, what does person-centered care look like in the context of BPD and clinical settings? And how do you create a space for individuals with BPD to feel seen and heard?
Yeah, I would say, one approach to, providing care to patients, to individuals with BPD would be, dialectical behavioral therapy or DBT, and nowadays DBT comes in all kind of shapes and colors, in terms of its level of intensity in terms of the program, or therapy service sort of being offered. That being said, like I think it's good to be mindful that DBT is not is not necessarily the best approach at every corner. When a person with BPD is having difficulties or is looking for help. A patient-centered care would really focus on understanding where that person is at, what of the things that may be going on for them are most important. What do they want to focus on, and how what goals to sort of set for them. I think patient-centered care also is important to recognize that people do have some innate skills and abilities and healthy strategies to deal with their distress or with their symptoms, and so it's good to help them realize that and appreciate that and see their strengths, and then to kind of build on that and to incorporate that into new goals or new interventions. Yeah, and I think also too, like it's about having a lot of respect, for the patient, and by that I mean, um, you know, um, being being clear on what you're capable of, what your limitations are, what your own boundaries are for yourself and your practice. Addressing things that might come up, in the therapeutic relationship. Sometimes we think people with borderline personality disorder may be, too fragile to hear, to see us as a person or to hear what our experience is like with them. But the reality is I think they respond really positively to us being honest and clear about our own limits and setting kind of boundaries that allow us to be kind of consistent and empathic, and there'll be, empathic failures or ruptures or disappointments along the way, and that's life. That's about me being human as much for them, and just acknowledging that and kind of working with that, because I think certainly relationships help the recovery process immensely, and it's just good to keep all that in mind.
Yeah, wonderfully put. You mentioned some great aspects around being honest, being transparent. It's that setting expectations and really modeling that relationship. That is definitely very helpful. So thank you. And a follow-up for you, Andrew, is how do you approach stigma, both within the system and with clients in your practice?
Yeah, well, I think I think that's a great question, and sometimes when you're in the thick of it, you can, and there are patients sort of always coming to us. You forget about that, and we may just be seeing the tip of the iceberg of addressing people out there who may be having mental health struggles, in silence. And so I think, over the years, it's been important for me to be a voice, around, mental health issues, mental health care, and to participate in some of the advocacy, like the work with Unsinkable, for example, and I also think it's like important to just recognize that stigma can still be in the room, like in the office setting, in the hospital setting for that patient or that family, when the family may be really hesitant to look to their extended family for support because it means telling them about what's going on with their child or that kind of thing. And so it's very much it's very much sort of, at play. And I think, one way to tackle that is through education, seminars like this. And, the more we understand about things, the more comfortable we are with it. If you're trying to treat conditions, the more creativity and kind of hope you can have about what to do. So I think, education certainly plays a big role around that.
Yeah, thank you. We'll shift back to Maria Rosa next. Maria Rosa, can you describe a moment where you and your daughter felt truly connected, even amidst the challenges?
Oh, yeah. I'd have to say it was when she was self-harming. She was about 14. This was the hardest thing I had to witness. Watching your child purposely hurt themselves. She chose cutting. There was a moment where I shifted from asking her to stop to asking her why this helped her. The answer was so hard to hear, but so vital for me to understand. It shifted the pain for her. She stopped hurting internally for just a moment by causing herself pain in a different way. Because we connected that way, I was able to set up a plan with her around cutting safely. And we started talking about the hard stuff, like cleaning her razors, letting me know when she had cut, and caring for the wound afterwards. I learned that radical pain needed radical action on my part as her caregiver. We even put together a cutting kit, and she gave it to me to hold on to. So when she wanted to cut, she would come and ask for it, and I would not refuse giving it to her. But we did talk through what was going on, what were those feelings, maybe delay it. And sometimes it worked, and sometimes it did not. There were moments where she would cut, and all I could do was hold her and be there. And this meant everything to her. It reminded her how much I loved her and had accepted her. And I know this meant a lot because we still talk about it today. And she's 21 now. So, and she actually helped me put together this answer because, she's my sounding board now. We're there. I'm grateful that we're there. It was a long road. But that was my most, I think, moment where I just really heard her and understood her.
That was very beautiful. Wow. And a lot of emotions. And I know you're mentioning how grateful you are of the journey and where it's taken you. But I know that the steps that you put in, specifically as a parent, were detrimental to getting you to this point. And if other parents and caregivers and loved ones could support the way that you did, it would make such a difference. I would love to see it. And again, hopefully that progress is steady going forward. And the more that people are educating about that, they will take it up for themselves as well. So thank you for that moment and sharing it with us.
Thank you.
Andrew, how can practitioners model empathy when working with individuals with BPD, especially in acute care settings?
Yeah, look, I think, one thing is that, it takes a lot of courage to ask for help. I think especially like in the mental health world, in the context of like stigma, and I think people with BPD, in acute care setting, like in an emerge setting, they are unfortunately, a group that may, come in and out of that setting and not feel a whole lot better. They may feel misunderstood, that they didn't quite get the help, that they needed, in that moment, because, maybe they were just looking for something that can't be offered, or that, was overlooked for whatever reason. So I think, when I imagine, like, if I'm going to go and meet with somebody in an ER setting, one, I think it's like courageous for them to be there. Two, especially in the context of like, they may already have some feelings related to a previous experience, and so they might be just feeling like afraid of being in the setting, or already anticipating maybe some disappointment. And so there may be stuff just feelings related to being there, let alone with what may have brought them there, in the first place. And so sometimes it's like trying to recognize those things in the moment, even before getting into maybe what happened that brought them to the hospital in the first setting. I think if there's an opportunity to, based on EMR, to learn a little bit about the person before meeting with them, and then letting them know that, that I had a chance to review some of this stuff, might help with that sort of, uncomfortable sense of having to retell one story again, and so, I think it's easier to get to, to ask them repeated questions, but knowing that it comes from a place of, already having some, understanding of them. And like I said, I think it's important to, to remind, like, set some framework around, what's going to happen in this assessment or this situation. And, yeah, and then I think really try to, hear them out, and maybe the person that brought them, hear their perspective as well, and and try to really understand what's going on, what they're hoping for, and and then work with them to help them, acknowledge their resilient self, and make a plan moving forward.
Yeah, I really love all of that. Just tackling all of the complex factors that can influence, and not just, okay, this is why you're here. This is the next step. See ya, sort of thing. So that was amazingly put, Andrew. Thank you. This is a question for everybody. So what are some everyday actions that friends or family can take to better support with someone with BPD?
I can go first. Kind of before that, I just wanted to kind of acknowledge Maria Rosa. Like, I've always said, and it's not a joke, like, I'm still up for adoption. I think that, I've watched you navigate all of this, and it has been so, like, beautiful on your end as, a mom, to give up the ability to fix a child and walk with them. And, as much as the safer cutting kit can be, a little scary, it's one, harm reduction. I love harm reduction. But it's also created such a safe place where I'm not going to be judged. So good job. You raised amazing kids. And it's been a privilege to watch all of that. And Andrew, I know Vanessa and I were thinking the exact same thing, because we were making that connection. That as, you know, frontline workers that have taken our clients to the hospital, having a psychiatrist acknowledge that this was very difficult, right? Like, we do that. We prep our clients to be able to, you know, advocate for themselves and do all of the things that you would think is not that difficult for somebody to acknowledge. And you just saying that, Vanessa and I were like, gosh, that was so lovely, because we don't see that quite often. And you modeling that, and you're like, it's not that difficult to treat a person, right? Is huge. And also, as the person that's been in the hospital and not been treated like a person, instead of you're back again, having that gentleness would have been so helpful to 16, 17-year-old Maria. So thank you. And I think for myself, I talk about it a lot. I don't stop advocating for mental health and BPD, because education is power, and it's already not talked enough. So I always insert the "did you know?" And I wish that people would also ask me, what does this feel like to you? What are you experiencing in this moment? Can you help me navigate this situation with you? And having that, being curious about me, is like the best thing that you could do to any human, but especially for BPD.
To add to that, from a caregiver's point of view, is ask questions. We, the caregivers, we should be asking questions, and we should be accepting the answers. It's twofold. It's one thing to ask, what do you need? How can I help? It's another thing to receive the information. So being open to that and sitting with them, even if there's no answer, because you know what? Sometimes you don't know what you need. Sometimes you don't know what and how your caregiver, mom, dad, uncle, aunt, friend, teacher can do to help you. So sometimes it's just acknowledging that we're just going to sit in it for a hot minute until it can get to a place where we can start talking about it again. So just being present and remembering empathy and validation. When all else fails, empathy and validation. Those are huge, huge tools. Keep them front and center.
Yeah, I think even to build on what Maria Rose is saying is that you know the empathy and the validation is to try to is not is in part like reflecting back what you're hearing the other person say, but it's also kind of like imagining like like if that were to happen, what would be the next thing that they might be concerned or worry about. And so it's it's not kind of exaggerating the situation, but it's like, yeah, like I can see where I guess in any scenario, like just sort of like thinking of the next like worst thing that could happen. And so, sometimes you're doing that, people are like, yeah, like that's their mind has been wandering so much. And so I think part of just saying like, if that were to happen, what would be the worst thing that could happen after that? And even saying that out loud is a sign of validation. Yeah. And I think, I think that, I think a lot of the times, it's, this does require, work for every member of the family, and to be open to doing some of that, learning some of these skills. Distress tolerance skills are good for all of us, and having some familiarity with that, so that when you're the one suggesting it, it might not feel so foreign, but it's something that they know you're familiar with and comfortable with, and so it can be easier to say, let's try this, as opposed to saying, once you go, like, do your tip skill. When we've got some familiarity or shared experience with that, I think it can be more helpful.
Yeah, for sure. Thank you. And going off of that question, I'll pose a question to all of you again. And what are some of the communication strategies or tools that help to de-escalate conflict or emotional distress in BPD relationships?
And start. um, that's a really good question. There isn't anything that is right to say, and that's okay. And also, if I'm seeing you panicked and like, oh my God, kind of going into that like crisis yourself, I'm gonna panic and we're gonna match each other's crisis. And who's gonna de-escalate? One of us. And that's not necessarily helpful for, myself and the other person. And for me, again, it was really shifting the language into making it more like empowering. And it was also, as I did the whole DBT, and I didn't have, my mom navigate this with me. I think I just had, my friends and myself and Angus navigate this with me. It was using the same language that I learned to normalize it, right? Like we always say that, riding the wave. And, one of my favorite skills is the stop skill. And, kind of having somebody say, like this skill, like, what does it look like for you? How is this helpful? What do I need to do to support you? And that makes me feel like I'm in control when I'm already feeling like so not in control of this situation. And yeah, I think it's just like, don't match each other's crisis and distress. And I totally get it. As a, caregiver, I can see how like if roles were reversed, like especially with self-harm and suicidality, I get it. And again, I was already feeling a lot of shame, and my mom came with a lot of shame as well, and there wasn't that compassion. So realizing that it's okay to not have the right thing to say, and saying that, like, Andrew, I don't have the right thing to say, or I don't know what to say in this moment, but I'm just gonna be. And that's sufficient.
Thanks, Maria.
I think, building on to what Maria was saying, I always go to empathy is always first. And we also chose as a team. When I say a team, I'm referring to my family. And we came up with boundaries and routines together so that we could follow them and agree to them. And this is done obviously when things are calmer, when you're in a more proactive approach. And that helped us build the bridge, and we keep them there by staying empathetic and compassionate and validating and understanding of each other. I've had to set boundaries around bad language, even self-harm and suicidal ideation, So for example, around language, I would say, I know you're angry, but please don't use that language with me, or don't call me that. Around self-harm or suicidal ideation, I would say, I know you're hurting. Please share that with me. Bring me where you are. I can see you've cut. Let me help you take care of it. So it's calling things for what they are, because again, pretending it's not there isn't helpful. So creating those boundaries and talking about some of the harder stuff is almost what she preferred. Let's talk about it. Let's get this out. But it does have to come within those boundaries and within those limits. It's important to give each other some. I needed some too. There was some things that I was saying or not saying, and I needed to hear what those were. So it was two-sided. They went back and forth constantly.
Yeah, no, those are great suggestions. That some people maybe is in the context more of like with parent caregivers and their children, like just like picking a word, and if the word is said, like the things just stop, and it may sort of come back to things. So I think it's really just like to stop everybody in their tracks, and like this is getting too heated. We need to pause this and step away from this. Yeah, I think looking for those opportunities where things are calm too, as Maria Rosa said, like to sort of to talk about communication and how to talk about feelings and other things that are going on at a different, more sort of difficult point. Um, yeah, look, I think like anger is such an important emotion, and that can certainly be an intense one for people with BPD in terms of how they feel it and maybe how they express it. And I think it's, we really want to acknowledge that feeling and then work towards like finding, healthier ways to express it. Um, yeah, and I think sometimes pattern communication style sometimes there can be a lot of you did this, you did that, and that can certainly go back and forth. And encouraging people to feel and take control of yourself in those moments is kind of getting into the I state. How I'm feeling, what I need to do for myself right now. Helping people practice that and do that as a way to sort of ground themselves and feel in control if things are feeling a bit out of control in the context of a relationship communication. So there's some other thoughts to add.
Yeah, thank you all for sharing some of those strategies and communication tools that hopefully our audience can take with them as well. I want to pose a question as well to the rest of you. This is going to be our last question before we head into our Q&A, because the time has flown. I don't know how, but just the conversation has just been flowing so great. That we're going to leave with this question. So if someone is just beginning their journey as a supporter or as someone living with BPD, what is one message of encouragement or validation that you'd like to offer?
Clicked first.
Yeah.
This one's kind of itching, that there's hope and that you're not alone. And we need to talk and we need to share as a community, because we're all in different places and we can all learn so much from each other. And we don't have to carry this load alone. The support is a vital piece to sharing the load. Well, whether you're a caregiver or whether you're a person struggling with this diagnosis, seeing that there's an opportunity to learn from each other, that it's not an us and them, it's an us, period. That's been the best support, I think, that we can share for the ones we love and care deeply for, is to just be there and hold space and hold them and reach out to others, whether it's someone in your village or your own family or your friends or your medical team or teacher, like whoever. It's okay to involve as many people as you think can help, because this isn't a one-man show. nowhere near it. This is something that, you know, the more hearts involved, the better, is what I always say. So I think that would be something that I think I would have liked to have heard, because you just feel so responsible in the beginning as a caregiver. It's all you. You got this one shot, don't screw it up. And that's not at all what this is about. So I hope that helps anyone starting.
Yeah, thank you so much for that.
I'll quickly just mention, if you've been recently diagnosed, or in that journey, it sucks that people don't see what's happening, and there isn't a way that I can describe to other people what's happening internally to us. And it's really shitty, and that's okay. And it's gonna be shitty for a while, and finding people that are not gonna judge you, that are gonna ride the wave with you, and that you're not a bad person, because bad people don't feel bad for their actions, good people do. And coming from a place of shame and guilt, we're not bad people. And for caregivers, you're not bad parents or caregivers. I blamed my mom for the longest time until I realized that she did the best she could with the one tool she had, which was a hammer. When I needed a screwdriver, she had a hammer, and she went at this wall. And yes, she did damage, and you know, all of those fun pieces, but she tried. And I can't blame her.
Thanks, Maria.
Yeah, you know, to add to those lovely remarks, you know that yeah, I think that the growth that comes with the self-compassion, you know, and self-love does allow you to get to a place where Maria spoke of in terms of compassion and acceptance and forgiveness for, you know, those relationships in our past where, you know, where we may have had a lot of intense, you know, feelings, and ruptures, you know, and you know, but there's still room for repair. The other thing too is that you know, there's also like a, you know, like a kind of passion and intensity, and productivity and likability associated with people with BPD. You know, they're themselves, but maybe their condition also sometimes exaggerates those real kind of beautiful aspects of themselves too. And you know, and so just, you know, acknowledging that as they, you know, try to dampen other things in their life, you know, that their fire sort of continues in ways that really works for them.
Awesome. Well, thank you all so much for those last words of inspiration and encouragement. We're gonna take it to our Q&A session. We had a couple of questions come up throughout the chat that we have reserved some time for our panelists. And the first one, so from our audience member Fanar, they had asked, what change or impact, positive or negative, did you receive after visiting a psychologist, psychiatrist, or therapist?
I think it's about finding the right fit, and that not all psychiatrists are, you know, mean or like grumpy, whatever. Like, you know, this is why Andrew's here. And it's finding that fit that is gonna help that puzzle piece. And also for myself, again, child and adolescent psychiatrist. But I have healthcare providers that continue to advocate for the lack of want to work with people that are complex. And you know, I'm one of them, and I continue to advocate for that complexity of what is a human. So there is a lot of good than bad.
Going to build on that to a therapist, but a therapist for the caregiver. Being able to get help for myself, where, you know, we put even boundaries within my appointment where it's like, okay, half an hour, we're going to talk about this, you know, her, them, whatever was going on with my children. But then the other half an hour was going to be about me and doing some work for me so that I could have the tools and I could do the healing and I can participate in the journey as a human, because I was given permission by a therapist to be a human being, that I didn't always have to be mom. And that was okay. That blew my mind. I also didn't understand at all what she meant. So it also opened the conversation to what that could look like in a safe, supportive way for my kids. And in doing that, giving them the safe space to look at me differently, that I was more than just a mom, that I was Maria Rosa, and I had interests and I had needs and I had emotions and I had feelings, and wow, that blew their mind. So all of a sudden we became this team. We were doing this together. It was a sink or swim. So what do we want to do here, guys? We going to swim today or are we going to sink? Whatever's going to happen, it's going to happen together. So that was a big shift that I have my therapist to thank for. And I will admit that I've been in therapy on and off and mostly on for about 11 years. So again, finding the right fit to help you, to help your child is huge and was a huge impact for me.
Awesome. Let's go on to the next question from our audience members. So Laura had asked, could you speak to how you recommend a person with BPD share their diagnosis in a new relationship?
I'll take this one. I'll take the team. I have no shame, and I know Vanessa does this too. I lead with my mental health, because then that way it like plugs out all of the things that like people don't want to like have that stigma, and then I'm like, I don't need to like be with that person. And it's also, yes, it is a heavy diagnosis. And also you being ashamed of it isn't gonna be helpful when talking about it to another person. And if that person's gonna be ashamed of that, oh, this person has BPD, you don't want that person. And the first date when I met my boyfriend 3 years ago, I word vomited, this is me, this is what I come, take it or leave it. That seems like a you problem. And then he was like, all right, this, and he was on it. And like, we've 3 years later, but it's also about taking accountability for my actions and my behaviors. And that recovery has given that to me. Because I can't blame him or anybody else for how I feel. But it is navigating that within yourself.
Very well said. Thank you, Maria. And then I believe we have one more question from Kathy. So how has stigma from society or professionals impacted your journey?
I believe it or not, it hasn't. Because I continue to show up for myself, and keep on talking about the uncomfortable conversations. When I worked at the hospital in the inpatient unit, having really difficult conversations with a psychiatrist, that level of power is very much there. And, sharing, hey, like, maybe we can frame this in a different way when it comes to somebody that has BPD. So because I know the stigma and I've felt it, I don't let that stop me from the work that I do in my personal or professional life. And I own it, and I will take it, and I'm not gonna hide from it, because there's no need to.
Building on what Maria said, again, from this perspective, I'm so proud of my kid. I allow and appreciate all the language and all the scenarios, and she has me in stitches over things that, oh my God, what did you just say? So many times a day. And I appreciate her vulnerability and her strength. So when I'm in the situation that I need to explain, I feel very confident in knowing that I might be explaining, but am I really? I'm rather saying something about how we've come to a place, and we can start talking about it, because clearly it affects the family. I mean, there are many things that she's missed because Pasadena wasn't there that day. So, how do you explain a missing child when, you're there and they're there? And I just felt so comfortable because she was comfortable. So it kind of goes back and forth. And in doing so, yeah, the stigma just kind of disappears, right? Because it's like she says, you say it like it is. There's no word, you're not hiding from anything. There's nothing wrong. It's uncomfortable. People don't like it. It's uncomfortable. People don't appreciate discomfort. But I've learned that it's through the discomfort that we grow. And we grow as people, and we grow as families, and we grow as a community. So that was kind of my aha moment. And again, because she taught me. So.
Yeah, absolutely. Regaining and reframing, and just taking ownership and getting that power back, absolutely resonates from what both of you had said. I believe that is or was our last audience question. So as we wrap up, I just want to take a moment to say thank you for being here, for listening, and for caring so deeply about someone in your life. These conversations can bring up a lot, and it's okay if you're leaving with mixed feelings, because that's totally normal. What matters is that you showed up here today, and that means something. And supporting someone with BPD can be incredibly hard, but it's also incredibly human. And we hope you're walking away today with a few new tools, maybe some new perspective, and definitely the reminder that you're not alone in this. And a big thank you to our panelists today for all of their honesty and wisdom, and to all of you for being part of the space with such openness. Take care of yourselves, and we hope to connect again soon.